Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Sarah Benner to the program.
Thank you.
You are a clinical psychiatric pharmacist at Peninsula Regional Medical Center.
Yep, that's right.
quite impressive.
Thank you.
And that means you specialize in medicines used to treat mental illness.
Yeah.
And that's the subject of our talk today. We are going to talk about depression and the antidepressant medications that are used to treat it.
Yes.
So let's start by a little overview of depression and what the typical signs and symptoms are.
Certainly. So most people are pretty common or familiar with depression itself. So depression is one of the most prevalent mental health diseases we have, and it tends to be genetically related, but not always. So most people with depression are kind of like Eeyore. So they tend to be sad, they tend not to have a lot of energy, tend to kind of withdraw from social interactions. Appetite sometimes can change. Some people don't eat at all. My roommate had depression. She ate tubs of ice cream every morning. It was just how her depression interacted with her.
So sometimes you see weight loss and sometimes you see weight gain.
Exactly.
Depends. Yeah.
Can see insomnia, often early morning awakenings, 3 a.m. tends to be really common right around that period of time, or you can see people sleeping all the time. So it's really going to vary from person to person, which is why it's important to always reach out to somebody, especially if they're having any thoughts of hurting themselves or somebody else. Suicidal thoughts tend to be very, very common with depression.
Obviously, better safe than sorry on those.
Exactly.
So let's first start by saying we agree on this, that all the literature says that you can't just treat with a medication.
Right.
There should also be some supportive counseling, multimodal approach to treating depression.
Definitely.
But I know you are here today to just review some of the major categories of antidepressant medications.
Yes.
So I guess the ones we should start with would be the SSRIs. So you can say what that stands for.
Yes.
And then we'll call them SSRIs, and you'll give us an overview of the class, some examples, how they work, and the side effects.
Definitely. So we know depression has to do something with our neurotransmitters. So those are the chemicals in our brain. Mainly, they've been looking at serotonin. So serotonin is one of our happy chemicals in the brain. So if serotonin's too low, we know that tends to lead to depression. So our selective serotonin reuptake inhibitors, or SSRIs, tend to be our first-line drugs that we go to. Really well tolerated, usually don't have a lot of side effects from it, and increases our serotonin in our body. These are things like Prozac or fluoxetine, Zoloft or sertraline, Paxil or paroxetine, Lexapro. There's a whole host of them.
And these have been around for how long?
Oh gosh, for 30 years at least.
Because all I remember when I first graduated from nursing school, which was longer ago than that, all we had was what we call the tricyclic antidepressants. And that's all we had, but they could be dangerous in some ways because of their side effects, creating risk for falls and so forth. So these SSRIs were truly, a big improvement.
Definitely. So our tricyclics were binding to a bunch of different chemicals and causing all sorts of side effects, even being lethal and overdose. But our SSRIs are really benign. We use them in kids all the time. We can have kids as young as 5 showing up with depression. We'll put them usually on something like Prozac or Zoloft.
What is the typical age you see depression?
It kind of varies, especially if there's a high genetic predisposition to it. Tends to be in your early teens, especially with those hormonal changes seems to trigger it. Anytime there's a change in life event, though, that can also trigger depression. So in your early 20s, we tend to see a peak, and then later in life turns our 50s, 60-year-olds. Again, with that change in life period, you see another peak with depression.
So you mentioned how they work. What are some of the common side effects? You're saying they're well tolerated, but there are some side effects.
Definitely. Sadly, I don't have any medications that won't cause side effects. Even sugar pills cause side effects. Usually think of the 4 S's with our serotonin reuptake inhibitors, or SSRIs. We have sleep changes, so people can feel more tired or less tired depending on how their depression impacted them. We also have stomach upset, so lots of GI issues in terms of nausea, vomiting, diarrhea, sometimes constipation. You can have sexual dysfunction, which can be a decrease in libido, could be difficult with orgasm, could be any variety of sexual impact, which is also impacted by depression itself, and suicidal thoughts. So this is usually early in therapy when patients are getting used to a new medication. All those chemical changes in the brain causes the brain sometimes to be overloaded. So you feel like crap, you have side effects, your mood's not better, and that could lead to more suicidal thoughts.
Just seems ironic that you're taking a medicine for depression, yet it can cause an increase in suicidality.
Right.
But hopefully, I guess that's a lower risk.
Definitely. Usually our higher risk patients are those who are under the age of 25. Once you get older than that, usually the risk is pretty minimal, especially those patients who are older than 65.
Okay.
But it is something we always watch for, always counsel people on.
Okay. And do these drugs cause weight gain? Because you hear people are very fearful of that. They think all these medications cause weight gain.
Sometimes they can. A lot of times Prozac, people say, doesn't cause weight gain. It can, especially if you've already had weight loss associated with any of your depression symptoms. Usually weight gain's pretty mild. It's a couple of pounds if you're going to see it.
Oh, okay.
But
in some cases, it's probably welcome if someone hasn't been eating. And...
Exactly. So it'll
Okay.
vary.
So then what is the next group of medications you'd like to talk about?
So the next most common will probably be our SNRIs. So that's our serotonin and norepinephrine reuptake inhibitors. So these are working like our SSRIs on serotonin, but they also work on norepinephrine or our adrenaline. So we know both of these chemicals tend to be low in depression and anxiety. So these are things like Cymbalta or duloxetine or Effexor or venlafaxine. There's also Pristique, which is coming out.
Yeah, that's a
more
newer
common.
one, isn't it?
Yep.
Yeah.
Desvenlafaxine, it's basically very fancy Effexor. Doesn't really do much other than that. With these, in terms of tolerability, they tend to be a little less well tolerated, but they are preferred for people who have things like diabetic neuropathy, fibromyalgia, or any sort of pain. Tends
So
to
they
actually,
kind of address the neuropathic pain too.
Exactly. Any sort of neuropathic pain tends to be really helpful with those.
And what about side effects? Are they the same or a little different?
Side effects are a little different. With them, they tend to dry you out. They have some anticholinergic effects with it. So you dry mouth, constipation, blurry vision. You can also see an increase in your blood pressure because it does have that adrenaline and norepinephrine effect. And you can see tachycardia with it. So people sometimes feel like their heart's racing and their heart skips a beat. Besides that, usually pretty well tolerated. Can see some insomnia as well since you have that adrenaline spike going on.
Okay.
But only during that first week or so.
All right, so what about the next category, your atypicals?
Atypical antipsychotics, or our second generation antipsychotics. These are some of our newer guys like Abilify, aripiprazole, Latuda, lorazepam. Sometimes you'll even see things like Seroquel or quetiapine. So while it says antipsychotic and people tend to get really freaked out when they get that handout, it's not being used for psychosis. It's not for paranoia or delusions. It's being used for that mood stabilization, especially when an antidepressant sort of worked a little bit, but not quite completely.
Well, I guess some people still remember those first generation antipsychotics like Thorazine, Mellaril, Haldol, and they had some really serious side effects.
Yeah, those were really tough to tolerate. Thankfully, our newer guys are much better with it, but they do have a risk for weight gain, diabetes, high blood pressure, all sorts of cholesterol issues, so we tend to be cautious with those.
So are these atypical ones used more for difficult depression cases, ones that aren't responding to the other two categories?
Exactly. So people who have tried multiple antidepressants and nothing quite works, or it kind of almost halfway works and it just needs kind of a booster with it. Or anyone who has any history of hypomanic or manic episodes leading more towards a bipolar diagnosis, we may use those.
Oh, okay. It's the old time ones, the tricyclic antidepressants. So talk a little bit about those, because in some cases they're indicated or may work.
Yeah, definitely. So our tricyclics are working on our serotonin. They also work on your adrenaline, and they work on dopamine. So they're increasing all your chemicals. Problem is, they also block all sorts of other things. So you can see anticholinergic effects, so you dry everything out, makes you very, very tired. People can get a lot of low blood pressure when they're standing up, so you see orthostasis leading to those fall risks. However, they're wonderful for people who have insomnia and have the neuropathic pain. So we tend to go towards those sometimes in our elderly patients, usually things like Pamelor or nortriptyline. But we also see them in people with fibromyalgia or any neuropathics, younger patients with Elavil or amitriptyline.
Right, that one's been around a long time. Yes. Both of those have, yeah. But you're saying we have to be careful using those in older adults because of the fall risk.
Exactly.
So last but not least, there is a class of miscellaneous drugs you'd like to talk about.
Definitely. So these are becoming more and more popular, especially if people have some cigarette cravings or weight loss. So there's Wellbutrin or Bupropion. Sometimes it's also known by 450. That's kind of the new brand name that came out because it's 450 milligrams, so 450.
Oh, okay. And I know that's also called Zyban when it's used to help quit smoking.
Yes, exactly.
Yeah.
So nice thing about it is it doesn't work on any of our serotonin. It only works on our norepinephrine or adrenaline and our dopamine, so you don't tend to have as much stomach upset with it. Problem is it can be very, very activating for people. People have a lot of trouble sleeping, so it's important to take it in the morning. It can also cause a lot of weight loss, which is great for some people. However, it can be an issue in anyone who has anything like anorexia or bulimia. And at very high doses can cause seizures. So anyone who has a seizure disorder, we tend not to use. But works very well for people who are smoking and trying to quit and have that depression.
And what about Remeron? Because I thought Remeron, I know you can take that in the evening and it'll help you fall asleep.
Yes.
So it kind of kills two birds with one stone, and I think it also helps with appetite. So people that aren't eating well, you kind of get 3 actions for the price of 1, I guess.
Exactly. So Remeron or Mirtazapine tends to be used more and more these days, especially in our elderly population or anyone who has cancer or HIV and really loses that appetite. But it is very sedating, so people tend to get more and more tired. Surprisingly, at lower doses, the higher the dose goes, the less sedating it tends to be. With it, it also is an appetite stimulant. So it's great for those people who have lost a lot of weight, not so great for those people who have gained a lot of weight recently. Can see an increase in your triglycerides and your lipids, so it's important following up with a doctor on it. Also causes lots of dry mouth, constipation, all the good things. So things we want to be cautious with. But can be very, very helpful for those who just can't find anything else to help sleep.
And with all these side effects, isn't it dose related too? The higher the dose you're on, you're going to have more issues. So just trying to get to that magical dose and...
Yep, least effective dose is what we're really looking for. So something that works well but isn't going to cause a lot of side effects. And it takes some time to really find that. And it'll depend on the person. Some people are really, really predisposed to having dry mouth. Some people never get it. So it'll depend.
Now, I know we wanted to bring up a couple other important points.
Definitely.
These don't work overnight, correct?
Correct. So these take about 4 to 6 weeks of a good dose in order to really see those benefits. Now, that doesn't mean people won't respond at all. Typically, they'll have a change in energy. Sometimes they'll feel like they can go out a little more, start, looking sharp, putting on makeup in that first week or two, which is why it's important they're having people they trust and people they're interacting with regularly who can reassure them, hey, you're looking really good, or hey, you seem to be doing a lot better before that mood's really stabilized 4 to 6 weeks out.
Okay. And the other thing is, if a patient has side effects, they shouldn't just stop taking the medication abruptly.
Definitely not.
I know you want to emphasize that.
Yes. So any side effects they're having, any concerns, even if it's just, I read something weird online, I think I'm going to have this side effect, call the doctor, or at least call a pharmacist, call someone and talk about it. Definitely don't stop a medication without talking to a doctor, because withdrawal symptoms are horrendous. People get lots of suicidal thoughts, they get more depressed, but they also have physical symptoms of it, which could be even tingling or visual changes. So just for everyone's safety, if they have concerns, definitely call a doctor.
So expect to wait a bit before you see a full effect from them.
Definitely. Not a quick fix except for ketamine.
And then, of course, they should be getting some sort of counseling or therapy to go along with it to help work through the depression.
Definitely. There's some sort of factor that caused that depression. While we do know it's a chemical imbalance, there's a trigger that led to things getting worse. So getting through therapy, getting in with a psychiatrist, meeting with a counselor regularly are really important, and doing good self-care. Sleeping at night, eating good foods, getting exercise.
That's good advice all the way around, isn't it? I know another thing we wanted to talk about is this booming area now of pharmacogenomics.
Definitely.
A fancy long word for looking at the genetic differences in people. And in this case, there can be differences in how you metabolize some of these medications.
Right.
So there's a new test out. It's called GeneSight.
Yes.
So tell us a little bit about that.
So GeneSight tends to be our most common one for our pharmacogenetic testing. There's a couple others that are now popping up, so people may have variations in it. But just like you said, it's looking at metabolism, so how well your body's breaking down those medications. Now, this sometimes gets reported as this is going to find the medication that's going to work for you. We're going to find the one that's best for you. It's not necessarily accurate. It's just saying how likely it is that you're going to get side effects from it or get toxic, or how well or how high of dose you're going to need based on how your body's breaking it down. So most of the time it'll look at your CYP enzymes. Those are kind of our enzymes that mainly break down all of our medications.
That's the CYP enzymes.
CYP enzymes, thank you.
From the liver that...
Exactly.
And if you don't have enough, then you're not going to break down the medication as well. You could get toxic effects more quickly.
Definitely.
And then the opposite can happen if you're an ultra metabolizer.
Yeah, then you break them down really rapidly, which a lot of times people, get to a good dose of something like Abilify, say it doesn't work. Well, maybe you just needed higher doses. But again, it only talks really about tolerability, side effects, and what doses we need, rather than here's your magic drug.
And the good news on that front is not only Medicare, but you're saying most insurances will pay for that test?
Definitely. All of our state insurances definitely do. Most of our private insurances are also now covering it. So for those who have tried a bunch of different medications, nothing's really worked, or they've had a lot of side effects from it, usually recommend trying it out, see how it goes.
Well, to me, it makes sense then going on a med and waiting 6 weeks or so for it to work, and up front having some information that might help you pick the better med that may have a better chance at working
Or at least
properly.
less chance of side effects.
Exactly, that too. So it just sounds like a great advancement in care and prescribing of these medications.
And they're getting better and better in terms of looking at it. They're looking at more factors, more risks for things like Stevens-Johnson syndrome with Lamictal or some of the other major side effects we can see. But again, still not finding that efficacy point, just the side effects.
Right. Okay, I know you wanted to talk about some resources, and you mentioned there's a website you recommend.
Definitely.
And then Peninsula Regional Medical Center has support groups?
Yes, so NAMI, or the National Alliance on Mental Illness, so that's NAMI, is a wonderful nationwide organization that's run by people like me, social workers, psychiatrists, who really want to advocate for mental health and make sure that people are getting the care that they need. So at NAMI.org or NAMI.org. They have resources for every diagnosis for mental health. They have resources about support groups, online post boards. Also, they have handouts developed by psychiatric pharmacists like me for every medication. So you can go in, figure out why am I being prescribed Abilify, and it'll not just say it's an antipsychotic, but it's also used for mood stabilization and depression. Also, every side effect you could think about, how it's dosed, things to do about missed doses. Easier to read than that size -3 font you get from the pharmacy.
Yeah, and it's just so many words. It can be daunting. Yeah. So, and the support groups, tell us about those.
So those are usually the last Tuesday of every month at PRMC down in their Hollowell offices. It's for family and friends with mental illness. So especially if people who have a mental illness have some family or friends who don't quite understand it or aren't very supportive, they can be referred to that. It's free. You can just show up. And you get to meet other people who are family and friends of someone who suffers from depression, from bipolar or schizophrenia, and really learn about the diseases, learn about the medications, and how you can best support someone else.
Well, that's the great thing about support groups. You learn you're not the only one.
Exactly.
You know, that there's other people in the same boat and can support each other. Is there a number people can call? We can post that at the end of the program to get more information, or if they want to attend, they can call?
Oh, yeah. And I know on NAMI.org, if you search for like support groups, anything like that, it'll pop up with what support groups are in your area.
Okay,
you can search by zip code even, so if people are up in Delaware, people are in Baltimore, wherever they are, they can find them there too.
Well, that's good to know, because people need help, and we may need to make it easier, I think.
Agreed.
So again, a big take-home point about these medications.
Definitely take them every day. Don't want to take them as needed. They take time to work. It's about 4 to 6 weeks, so got to be patient with it, seeing those small changes, and don't stop medications cold turkey.
And of course, if you're feeling depressed or think there might be a problem, see your doctor, because they have to prescribe these.
Exactly.
None of these are over the counter.
No, definely not.
I mean, there are a lot of illnesses where you can go out and try to self-medicate, but not in this case. So.
Nope.
Well, thank you so much for being on the program. Very, very informative and such an important topic.
Definitely. Anytime. Thank you.
And thank you for joining us for this edition of Focus on Health here on PAC 14.